today's echo session. It's great to have you joining us. It's an exciting topic today. My name is Matthew Gibbs. I'm an anaesthetist here at Grooteskier in Cape Town. I've got an interest in patient blood management for a number of years. I've been working with Vernon Lowe, working on hopefully on a PhD over the next little while. I just want to thank you for the opportunity to join you guys. Just a reminder that Project ECHO is hosted by the Gastro Foundation in association with the Project ECHO and the University of New Mexico. We have these sessions every Wednesday, which rotate through different topics, including gastroenterology, endoscopy, and hepatology, as well as patient blood management. It's wonderful to have participants from all over Africa. We've got 34 registrations at the moment, which is great, including those from South Africa, but we've got people online from Tanzania and Zambia and Sudan and Kenya, and it's great to have you participating, and look forward to some robust discussion later on. The chat will be open for questions. Please post, and we will discuss them at the end. I'd like to introduce our speaker today, Dr. Peter Wessels. We've already discussed that he graduated significantly before my time at TICS and specialized in hematology in '94, and has been doing clinical hematology at Wits until 2007. He's subsequently been working at Life Groenkloof. He's a consultant with Ampath Laboratories and has particular interest in thrombosis and hemostasis. So we're looking forward to hearing from you, Pete. And I think the topic is a really, really good one. And I'm looking forward to hearing from you. Thank you. Pete, can you unmute yourself?
Sorry.
There you go. All right.
I just couldn't find the. There we are. Let me just get to that. My mouse seemed the little. I'm working on a Mac, and you know what?
Once you go Mac, you can't go back.
I know, but the cursor, there's the cursor is back. That's fantastic, as long as the cursor is back. Okay, from the beginning, and there we go. Slideshow. Oh, can you see it? Is it fine?
Perfect. That's great. Thank you.
Okay, so the topic is really anemia in athletes. I think the first thing to say is that an athlete can have the same type of anemia than anybody else. So this is not really this. If we need to make it a total topic discussing anemia in athletes, I think we need to talk about folate and B12, aplastic anemias, etc. This is not what it's about. This is more about specific anemias that we see more often in athletes. And I thought for the content to look at the following. First of all, to look at the changes in physiology in athletes, especially in endurance athletes. The blood volume changes, the immune system changes. There are also some coagulation changes in these athletes. And then iron in athletes, the need of iron in athletes, and the diagnosis, especially in an athlete. It's not easy, always as easy as in a non-athlete, to make the diagnosis of iron deficiency. And then how do we treat them? And then just a few slides on blood doping. I think it's interesting to see what people have been doing to increase their ability to carry oxygen. So the first thing to talk about is the dilutional effect. And this is really a term called sports anemia. Now, what really happens, I'm just going to take this away, so otherwise it's going to bother me. Okay, so sports anemia, it's really with acute exercise, what happens is that there's a reduction of about 10 to 20% of your plasma volume. And that is because there's a rise in your blood pressure, and you can, the muscular compression increases the fluid pressure into the intravascular system, and you increase your GFR. But the other thing that really happens is that inside the muscle, there's buildup of lactic acid and other metabolites, and that adds as a tissue osmotic pressure, pulling the plasma fluid but not the red cells, into the tissue. And you also lose water by sweating. So this then is the acute phase. After this, there's an overcompensated replenishment and in the recovery period. And what really happens is that there's higher renal sodium reabsorption. You increase your plasma protein production, and this increased plasma proteins move into the intravascular space, and the patient is thirsty and increases hydration. And if you look at the picture down here, I hope you can see my little mouse now. This is the normal patient. This is a normal volemic anemic patient. But really what happens is that in this phase, the patient gets a dilutional anemia. It's really, there's an increase in red cells, but not as much as the increase in plasma volume. So this overcompensated post-exercise increase in blood volume, not always red cells, blood volume happens. And it's mostly, it's not seen that much in swimmers and other athletes, but it's in the running, cycling, triathlon patients. And they can really increase their blood volume with 30 to 40%. And if you read this article, it's a little bit old, but it's still interesting to read. What really happens is that these patients can have a blood volume, not of 5, but 7, 8 liter. So that's the first thing that happened. If you look at the full blood count, you will get the impression that they're really anemic, and they're not really. And this sports anemia, in other words, this dilutional anemic picture that we see, doesn't influence the exercise capability, but this is a dilutional thing. It's the same thing that happens in pregnancy, really, but so it's a dilutional effect. The second thing that really happens with these patients is that the immune system, there's a change in the immune response. And if you do a full blood count in an extreme athlete or just after exercise, you often see this neutropenia. And this is because there's a decreased overall survival of the neutrophils in these patients. The other thing is, as I said, we do get the plasma volume expansion, so you get dilution of your white cells as well. And many times these patients use drugs like indomethacin, which can give bone marrow suppression and kill off your neutrophil production. But then there's something called eccentric muscle damage. What eccentric exercises is that if you do an exercise and the first movement, for example, if you pull something, the release, in other words, the recovery phase is done very slowly, and that's eccentric muscle movement. And it's in that phase where you, for example, if you lift something, but put it back very slowly, that eccentric muscle movement is which damage, you get a lot of muscle damage there. And what happens with eccentric muscle movement and exercises is that they need monocytes and neutrophils to move into these damaged muscles, and then there's a decreased number inside the blood. And there's also exercise-induced lymphocyte apoptosis in these patients. And now if you look at this, this is just an indication. You can see that the darker line, that's the athletes. You can see that the athletes has lower neutrophil counts, lower lymphocyte counts. The monocytes not always, but you can see those two especially in these patients. The other thing that happens with these patients, they have during exercise, there's an acute phase response. They have increased interleukin-6, and it's an acute phase response followed by a recovery, post-exercise recovery. And every time after with recovery, they sort of reset after a while. They reset their baseline values. In other words, for many of these markers, and you can see here again, the total white cell count lower in athletes, haptoglobin, which is acute phase protein, lower, CRP, you can see much lower in these patients, and then transferrin, which is a negative acute phase protein, and albumin, negative acute phase protein, they increase. Iron, lower, not that that makes really sense, I'll tell you a little bit later, but the ferritin levels lower, and this is not only the acute phase, but it gives you an idea of what is coming. So the ferritin levels lower in these patients. Bottom line is this, these patients have a less of an inflammatory response. It can be due to the lower levels of abdominal fat as well. We know that the adipocytes in the abdominal fat really are one of the main reasons for inactive patients to have an increased inflammatory response. So it's got two things. It's got the decrease of abdominal fat, in other words, decreased inflammation, but also this acute phase response after exercise, and then resetting at a lower level every time. In other words, decreasing the inflammatory response. If you look at coagulation, we all know that. I can just quickly tell you that with acute exercise, you also get an increase in your platelet count, and you also reset it. But something else with chronic exercise that happens is that your platelet receptors change. In other words, a patient that's really much fitter don't have this hyperreactive platelets than unfit patients, and for example, diabetic patients have. Now, the main talk is really about iron. And if you look at this, this is just an idea of the Earth, and you can see that the crust of the Earth, 5.2% of the crust of the Earth really consists of iron. But despite that, we have about 1 to 2 billion iron deficient people on Earth. We're about 7.9, 7.8 billion. But just look at the number of patients. Despite this element being available, we still have a lot of iron deficient patients. And this, it's because of this. Now, you may find this boring. Maybe everybody knows this. I'm just going to go through the physiology. I won't spend a lot of time. But I think it's important to understand this, because this will explain to us why iron, large number of athletes are really iron deficient. So the control of iron is really by intake and loss. So we need 1 to 2 milligrams of iron per day. We lose 1 to 2 milligrams a day. And we lose it by desquamation, other blood loss, soft mucosal cells, menstruation in females, so they need more. And then in the duodenum, the uptake is about 1 to 2 milligrams per day. In the muscles, we have about 300 milligrams of iron. In the bone marrow, about 300 milligrams. And you can see that the largest number of iron molecules is really in the red cells, 1,800 milligrams of iron there. And then in the reticular endothelial system, remember this is the spleen. Remember, a red cell lasts about 120 or 90 to 120 days, depending. But the red cells are then broken up inside the right intestine, the spleen, and the RE system. And they being broken up, everything is reused, especially the iron, and the iron is then goes back into the circulation, kept then go back into the circulation, being available for red cells production again. And in the liver, we have a storage. So if you look at this, we have about a 25 milligrams a day of iron being utilized the whole time. Our total iron is about 3 to 5 grams. That's it. But we know that the intake is 1 to 2 milligrams and the output is 1 to 2 milligrams. So most of this iron that we use here comes from recirculation, from these red cells being broken down. So just keep that in mind. Now, the control of iron, we know iron partake in the redox reaction, so the iron electron transfer. So iron is really important in carrying oxygen with hemoglobin, and iron is also important in the mitochondrial system, inside the mitochondria, where you have electron transfer in producing ATP. So if you have an iron deficiency, you have a defective production of energy, and that's the first thing that you would give up. Long before you're anemic, you won't be able to have effective ATP production, and that's important for athletes as well. So the control of iron is really being released from stores, being released from the reticular endothelial system, and the uptake. We have no control over our loss of iron. If we look at the intestine here, I'm sure you guys know it very well, but heme iron, in other words, the iron that we find in meat, is much better absorbed, and there's a specific absorber transporter. The process is much more efficient there. And then we have iron in non-heme form, but in the ferric form, that needs to be changed into a ferrous form to be absorbed through this divalent metal transporter inside the cell. Once it's inside the cell, it needs to move into the blood. And that's the gateway. I'm sure everybody knows this. Just going to go through it quickly. So the ferroportin and the basal part of the duodenal cell is the gate. That's the gate allowing iron to go into the system. So you can have the iron sitting here and it can't go through. So bottom line is, and then there we have sucrosomal iron that can go through in between cells and the lymphatic system. But bottom line is this. So this gate is where the total control of iron uptake is, and iron, the same gate is on the cells that keep on the stores. So that same gate is on the stores and on the gut, and the gate is controlled by something called hepcidin. Hepcidin is a hormone produced by the liver, and if hepcidin is released from the liver, it binds to this gate. The gate internalizes, and iron cannot be absorbed. So whenever you have an increased hepcidin level, you will not absorb iron. So let's quickly look at this. If depending on the food stuff that you eat, it does influence the iron uptake. We know that meat has got much better absorption, and it increases the absorption of iron, even the ferric or the ferrous form absorption. Vitamin C in high dosages increases it. We're not 100% sure, but we still believe it. Organic acids can increase it, but some of the acids decrease it as well. For example, tannins decrease absorption. And look at the spinach, decrease absorption. So, and often athletes eat a lot of they are so involved with vegetarian meals and eating a lot of spinach, etc., that this really decreases the absorption. But I'll show you later. Just keep that in mind. But the thing to remember is the ferroportin gate. As I said, vitamin C, we're not 100% sure that it does increase the absorption. And then PPIs can also decrease your absorption. Just to remind you again, 25% absorption there, 2 to 13% absorption here. In other words, much better absorption if you can, if the patient is not vegetarian. The one thing to remember as well is that the iron in the gut, in other words, that is not absorbed, influences the hepcidin release. So if you have a lot of iron here in the gut, you increase your hepcidin and you won't absorb. So you do not want a lot of iron inside the gut. That will decrease your absorption. And this is also the mechanism why we say that we give patients alternative days oral iron, because we know that if you give somebody oral iron, they do absorb it, but they have an increased hepcidin level, and that, so if you give a BD dose or you give everyday dose, you're actually just increasing the iron here, and you increase the hepcidin and it doesn't work. So that's why we really believe that once a day, alternative days, oral iron is really the best way of treating iron deficiency. If you're not going to be another form of iron. So hepcidin, just again to explain here, hepcidin is made in the liver. It's an acute phase reaction. In other words, as soon as you have an increase in interleukin-6, remember I said exercise gives you an increase in interleukin-6. So if you have a cytokine, any inflammatory process, you get increased hepcidin, and the hepcidin will block your absorption from the gut and your release from your stores. What would decrease your hepcidin? Renal clearance, and if you have a low saturation of your carrier protein transferrin in the blood, that would increase it. And pregnancy would also decrease your hepcidin. And here, hypoxia. Hypoxia is an interesting phenomenon. Remember, hypoxia, I'm going to show you a little bit later, but hypoxia then decrease your hepcidin levels. So in other words, you will have an increased absorption of iron. This is an even better way of explaining hepcidin. So what would increase your hepcidin levels? And if you have then increased hepcidin levels, that means that you will not release iron from the stores or take iron from the gut. If you have kidney dialysis or kidney disease, decreased GFR, red cell transfusions, oral iron or IV iron, replete iron stores because you don't need to absorb. There's this disease where you have very high hepcidin. It's rare, but you have very high hepcidin levels. And then inflammatory or infective disorders like exercise also increase your hepcidin level. What would decrease your hepcidin level? If you have expanded erythropoiesis because you need iron, anemia, especially and hypoxia, and especially iron deficiency anemia. Erythropoietin will decrease your hepcidin. Chronic liver disease, alcohol, Not that that would be the ideal way of increasing it, but it may help. And then genetic and hormonal, some of the hormones will decrease hepcidin. In other words, this, if you use this, you will increase your iron uptake. Okay, just to give you an idea. And so, how do we then, if we have an iron, what is the difference between an iron deficiency and a functional iron deficiency? A real iron deficiency means that there's not enough iron in the blood carrying protein called transferrin. You will have decreased hepcidin. You will then increase your uptake from the gut, and you will increase the release from the stores. A functional iron deficiency means that the saturation is low, but the hepcidin levels are high, for example, with inflammatory response, etc. You will stop the absorption and stop the release, and it will look like an iron deficiency, but it's not. It's really just a low saturation because of the stores and the uptake being blocked. So, and the reason why I'm showing you this, I'm going to show you that athletes is around here. So what really happens with if you look at iron-restricted erythropoiesis, in other words, this is now a red cell production with a decreased iron, but it doesn't mean that it's an iron deficiency. On the one hand, you have an iron deficiency. This means that the ferritin is low, and this is a value that's really, really low. I'll show you in athletes what's suggested. Or the transferrin saturation is low. If you can't trust the ferritin, and we'll talk about that in pregnancy, 30, etc., or sick patients. But bottom line is this is when it's real. You haven't got iron. But a functional iron deficiency means that either you've given somebody erythropoietin and they can't keep up by supplying, or they have a block. And this is normally where you give erythropoietin to patients with cancer and chronic kidney disease. They can't keep up by supplying iron. So it looks like an iron, it's a functional iron deficiency. It looks like a block. And then anemia of chronic disease, which is the most common form of anemia in any hospitalized patient, is the anemia of chronic disease. As soon as you have an acute inflammatory response, you will increase your interleukin-6. It will increase your hepcidin. You will block the uptake of iron. You will block the release of iron. And the patient will look as if in time they will have initially a normochromic, normocytic anemia, but in time will develop a hypochromic microcytic anemia as if they're iron deficient. This is the last slide on this issue, but just to give you an idea, so you can have an absolute iron deficiency, or you can have a functional loss because you cannot give enough, for example, with erythropoietin given to a patient, or you can have an inflammatory response. And in these cases, you have enough iron. It's just a question of mobilizing it. Now, back to the athlete. So if we look at athletes, about 15% to 35% of female athletes are iron deficient, and 5 to 11% of male athletes are iron deficient. So what is the cause of iron deficiency? Remember I said iron control lies with the release from the stores or the uptake. We cannot control loss of iron. So iron deficiency, it's like money. If you haven't got money, it's because you didn't earn it. So decreased absorption, or you used too much, you bought something expensive, you had an increased release, or you lost it, somebody stole your purse. So it's exactly the same mechanism, either a decreased absorption or increased need or increased loss in athletes. Now, the decreased absorption in athletes, remember I said with acute exercise, or actually any exercise, but especially in the endurance, serious athletes, they get a very high interleukin response, and the hepcidin increases 3 to 6 hours post-exercise. Now, in other words, immediately after exercise, there's a gap, but then there's an increase in hepcidin, and this exercise-induced inflammatory response is due to the interleukin-6. But what then happens is that if an athlete exercises and eats within the first 3 hours, he will absorb iron. But if he eats or he takes his iron tablets post-exercise, 3 to 6 hours post-exercise, he will not absorb it. So there's a transient window of opportunity after exercise where nutrition strategies need to be done. So what these athletes need to do is they need to really decide when to take their tablets and when to take the feeding. There's a window of decreased absorption with a high hepcidin levels. That's one of the reasons why they have a iron deficiency. Then there's something called RED-S. Now, this is a relative energy deficiency in sport. And what it really means is that patients cannot keep up by eating enough or supplying enough energy. So there's a negative energy balance in these patients. And this goes hand in hand with iron deficiency. And then the other thing with athletes is that they really, especially the figure skaters and people like that, they have lots of weight loss planning. And then, as I said, many of these patients are on strange vegetarian diets. They really health conscious, and they may be vegetarians and they don't eat. This is just an idea. This is also an interesting article to read. If they have an iron deficiency, it's got a serious negative effect on them. And plant-based food, this is a plant-based diet. Some of the plant-based diet has got a good effect, but they can develop an iron deficiency. And if you look at this is the stuff that they should be eating if they're vegetarian: beans, peas, lentils, edamame, chickpeas, nuts, etc. So this is really one of the reasons. So it's decreased absorption, and it's decreased absorption due to an acute phase response, due to exercise, or all the other reasons that the patient might have. And then the second thing is that athletes are really, they have an increased need of iron. Remember I said 1 to 2 milligrams a day. So elemental iron, we need at least 8 milligrams for males and 18 milligrams for females, but athletes require much more. And they looked at an international group. You can read this if you want to, but it's interesting. They have an international endurance athletes, and what they've done, after intensified training, they gave them 13 to 18 milligrams of elemental iron every day, but they still dropped their ferritin. And this is just an example of one such a patient. This is a serious endurance athlete. And what has happened with this guy is you can see after each exercise, that the black is after each exercise, you can see his ferritin level goes up. We said it's acute phase response. You can see after exercise, you cannot trust these levels at all. That's not his true ferritin, that's just after exercise. But then you can see, and this is the pink background, is him having iron supplementation, 100 milligrams a day. So elemental iron is enough. And you can see he drops his serum ferritin every time. You can see, despite being given iron supplementation. So they're really always on the low side, and there are different other reasons, and I'll show you a little bit later why. This is one of the reasons. They have increased loss. Remember I said we have no control over our iron loss. And one of the reasons people think maybe sweat, but it's quite a low iron content in sweat, so 2.5 micrograms of iron per liter. You really need to sweat a lot to lose iron via sweat, but it might be a confounding factor. But with athletes not having the correct shoes, etc., they can have foot strike or march hemolysis in their feet. And then with this, remember I told you about the eccentric muscle damaging exercises where you move muscles slowly back to the position. In those patients, they can have hemolysis as well. So it's definitely a factor. Hemolysis plays a role where you have breakage of red cells, and then you have a loss of hemoglobin in the urine. Hematuria, and this is especially in the runners. What happens, the posterior wall of the bladder hits gets hit, and the bladder is fixed. So during running, you get a breakage of red cells in that area, and there's also renal ischemia in these patients. Another reason for iron loss is gastrointestinal bleeding. If you look at endurance events, occult stools, 13 to 85% of these athletes are positive. And it might be due to visceral ischemia as well. You can see here, exercising at 70% of their maximal VO2 maximum, what happens is that they have reduced blood flow. And if they go to 80%, it's even worse blood flow. So you really get ischemic, visceral ischemia in these extreme patients due to splanchnic, decreased splanchnic perfusion. They don't use it there. And if you check these patient endoscopy, you can find gastritis, esophagitis in many of these patients, but also small bowel and colonic ischemia. So and again, it's more often seen in runners than in swimmers, etc. And then there's also menstruation in women. So why do athletes get iron deficiency? They have decreased absorption because there's only a window where they can absorb iron, because they have this increased hepcidin, which blocks the absorption of iron. That's the one thing. They have increased need. I showed you the ferritin levels fall despite replenishing them. And there's increased loss, and I showed you, so it can be sweat, it can be hemolysis, can be through the urine, skin, and also gastrointestinal loss. So if we then look at iron deficiency in these athletes, there are 3 stages. You can have a stage 1 where the patient, really the HB is normal. It's just the iron deficiency. And this is like normal patients when we know that you have patients with the iron deficiency. The spleen and liver are depleted. The ferritin is on the low side, 35. I think it's a good value. I love it when they say 35 is a normal. The HB is still normal, 11.5 gram per deciliter, and the transferrin saturation is okay. So this is where just the stores are low. The ferritin is low. It's just the stores, nothing else. Stage 2 is an iron deficient, non-anemic patient. And here you have a saturation of less than 16%. And in other words, you've stopped making red cells. And the ferritin is low. The HB is still normal. HB is still normal, but the transferrin receptor is low. And then you have an iron deficiency where the HB starts falling, resulting in anemia. Ferritin is really low. As I said, HB is low and transferrin saturation 16%. Now, take into consideration that the problem with athletes are that some of these are acute phase proteins. Transferrin is a negative acute phase. Ferritin is a positive acute phase protein. So you really need, it's not taking a iron study like in any other patient. You need to really think very carefully when you take the blood and what it means. One way of looking at athletes is looking at the transferrin receptor. Remember, the transferrin receptor is that receptor on the cells that need iron, on which the transferrin, which is the carrier protein in the plasma, will attach. And if there's a need for iron, you will increase your transferrin receptors, and that's it's shed into the plasma, and we can measure that. So if you have an iron deficiency, you increase your transferrin receptors. So if a level of 2.5 milligram per liter is considered a reasonable threshold. Now, the problem with transferrin receptor testing is that it's not always 100% standardized, and that's why it's being done, and I think it's a fantastic test if you're unsure whether somebody is iron deficient or not. Now, this is a good article, a narrative review. It's good to read if you're interested in this. And what it really says is the following. You need to think about the variables. Which test to do in these patients. You can do a ferritin, you can do a transferrin saturation, in other words, iron study, and you need that. That's the minimum that you need to do in these patients. But it's better to also do the transferrin receptor, the hemoglobin mass, which you can't do really easily, but can be done, and then the CRP, because the CRP will give you an indication of whether you can trust the ferritin. The other thing to think about in these patients is when to do it. It should be done in the morning. The patient's hydration state should be good, because remember, these athletes it depends on what they've been doing. If they've been exercising, they've lost their plasma volume 10 to 20%, or if they're in the reactive state, they can increase it. So you really need to know where you stand with these patients. And then they need to be without exercise for 24 hours when you take the blood. Otherwise, you can't trust it. As I said, you get this acute phase response, and all these things get haywire, and you don't need what need to do. And especially if they've been doing these eccentric muscle exercises, they need to 2 to 3 days stop that eccentric exercise. Otherwise, you can't trust your iron studies, and they shouldn't be sick. So how often, if you have an athlete, I don't know if you treat or see these patients, how often should you check these patients? So you can do it annually, biannually, or quarterly. And if there's no history and the patient is fine and he doesn't complain, the one thing that they really make a point of is the athlete will tell you that I'm really tired, I tired easily. So if there's no evidence of low energy availability, it's fine, you can do it annually. But as soon as the patient complains that they prolonged fatigue after extended rest, in other words, they have rested but they're still tired, think of an iron deficiency. Because remember, iron doesn't only supply oxygen, it is important for the ATP production in the mitochondria. And then even quarterly in a patient, if there's been a history of iron deficiency, and when the patients are going to go into an hypoxic state training. So what these athletes do, they live high and train low. So they live in a high, low oxygen availability area, and that causes an increase in the erythropoietin. So they increase their red cell production. But in those patients, you need to check very carefully. And it's been shown that they really need, if they do that, they really need iron supplementation. So this is really the tests. I told you serum iron, but there are some tricky things. Serum iron has got a diurnal rhythm. If you do a serum iron during the day, you can just as well leave it. It should always be done early morning because there's a diurnal rhythm. And if the serum iron is low in the afternoon, it will give you a low saturation and you'll think that the patient's got a chronic disease. So if you do iron studies, do it in the morning, it's much better. Negative acute phase protein, positive acute phase protein, and quite reliable. So just to give you an idea of where and what these tests mean. And I'm not going to go this, I'm sure you guys know this much better than I can tell you, but bottom line is this, a low ferritin is almost always an iron deficiency. A normal ferritin can be an iron deficiency as well, but if your saturation is low and you have a normal or high ferritin and the receptors are normal, think of a chronic disease or functional iron deficiency. Functional iron deficiency meaning that you cannot keep up like in the athlete. You cannot keep up in supplying enough iron, or there's a blockage, or you've given the patient erythropoietin and they cannot keep up like a kidney patient or a cancer patient. Okay, so just to finally again, ferritin increase after intense exercise, be careful. HB is affected by the shift in plasma volume. Remember, I told you these patients are really, they're changing their plasma volume, whether training or adaptation or post-training. To think about that, you can't only look at an athlete's HB and say he's anemic or not. So no muscle damage is exercises 2 to 3 days, and as I said, do it in the morning, check their gravity, and rather give them an overnight fast. So how do we manage these patients? We assess their iron deficiency, whether it's iron deficiency, in other words, where do they fit? Are they really iron deficient? Are they iron deficient with non-anemia, or are they already anemic? And remember, this anemia, keep in mind, sports anemia. That's why I showed you in the beginning. Don't just say it's anemia. Think about the total mass of red cells the patient has. And then you need to think about the timing that you have to rectify this. If this is an endurance athlete that really need to go to Olympic Games, it's a problem. You need to think about the legal aspects, because I'll show you a little bit later, because this may influence the athlete passport. And then think about underlying conditions. Look at they need dietary assessment, and they need a dietitian to look at it. You can give them oral supplements, which increases their ferritin 40 to 80%. If you give it alternative days with 100 milligram, or intravenous iron, that gives a much better increase in ferritin, but you need to make sure that they're allowed to have it. And then you maximize the supplementation during the low activity period. In other words, in the winter or whenever it's not their season of really exercise, but they tend to have the whole year. But in those periods, you need to really top them up, in a sense, making sure that they have enough supplementation. So the decision is really made by a sport physician with a dietitian. So, and you know this, I don't need to tell you, there's poor absorption, concomitant food, I've showed you, and compliance is a problem with oral therapy. You can give them intravenous. So we've just now been talking about this endurance athletes. What about people going for a walk? Middle-aged men like me, older men like me, women going for a walk. And what they've done, they've looked at them. If you take, and this is not just a walk, this is quite a walk, but these patients, they walk a few kilometers, and what they've done, they've looked at them. They looked at day one, for 5 days, what happened. And this is really what happened. Remember, I said acute phase, acute response. Look at them. They have an increase in their ferritin. The iron went down, the heptoglobin went down, then it went up, and hemoglobin went up. So even in just walking in the normal patient, you have these changes. That means that often you do iron studies. You can't just interpret an iron study without knowing what the patient has been up to. So the last part is quickly 10 minutes or 5 minutes on how do these patients, these athletes, what do they do to increase their capability, their exercise capability. The first thing I quickly want to show you, I'm sure a lot of you know this, there's something called hypoxia-inducible factor. Now, hypoxia-inducible factor, 1995 or 2005, described now, what happens with this hypoxia-inducible factor, if you haven't got hypoxia, it gets excreted and broken down. But as soon as there's hypoxia, if you haven't got oxygen, it goes into the cell and it attaches to hypoxia-inducible factor beta, and then it will change the production of certain hormones, for example, erythropoietin. So this is really the way that your kidneys will decide to increase erythropoietin production. It's via the hypoxia-inducible factor alpha subunit that's not degraded, that attached to hypoxia-inducible factor beta, and that will then lead to expression of certain hormones like erythropoietin. So, and then erythropoietin, what it does, it increases the production of your red cells. So these parts are erythropoietin dependent. And if you have a chronic hypoxia, what it means that within 90 minutes, if you have chronic hypoxia, within 90 minutes, you increase your erythropoietin production. And within 48 hours, it peaks. And then in 10 days, you have an effect. So it gives you an idea. So this is one thing that they can do. They can give themselves erythropoietin. The advantage is that it will increase the hemoglobin, it will increase the oxygen carrying capacity, and it will increase the maximal uptake and improve their stamina. But the down part of this is it will increase their blood viscosity. Remember, they're already running with an increased volume. It increases the risk of stroke, heart attacks, venous thrombosis, elevation of blood pressure. And there's also this risk if you give erythropoietin to a patient where they can develop antibody formation and then potentially risk of pure red cell aplasia in the bone marrow. So this is one way of increasing your red cells, giving yourself erythropoietin, or the athlete giving them. Something else that they try to do is they remember hypoxia-inducible factor alpha needs stabilization and attaching to the beta unit. And what they've found out is that the argon, xenon, and cobalt stabilizes this. And it's been said that in 2014, the Russians used this xenon gas to increase their athletes' capacity and the red cell production. So that's another way. Then there are the rest of the red cell, and then we have stuff called perfluorocarbons like Hemopure. This is artificial oxygen carriers. You can see how small it is. And these carriers will then carry oxygen. And it's really, it's got its own advantages. The big disadvantage is that it scavenges also NO, and you can get vasoconstriction in these patients. Something else they can do is they can do transfusion. I just want to show you something. If you give somebody transfusion, there's also some chemicals like the plastic or the tubing. And so if they give themselves blood, they can do a homologous transfusion or autologous. Homologous, it's easy to pick up because you can find the other patients. You can look, even if they have a good match, you can find the other minority blood groups on antigens on the donated red cells. So that's easy to pick up. The problem with autologous donation is where a patient would go and donate and exercise and donate, and just before a event will then get his own blood back. And there's now a specific test that can really pick it up. But what they can do is they can look for the plasticizers. In other words, they can see it, and they see changes in hepcidin. Remember, I told you hepcidin increases with transfusion, and they can see that, or they can look for microDNA in these bags. So there are ways of doing it. The way of managing this is really having an athlete biological passport, and this is an anti-doping tool. And what they really do is they have longitudinal monitoring. In other words, if you're an athlete and you exercise, you'll have an increase in your hepcidin. The hepcidin will drop, your ferritin will drop. So there's expected changes with exercise, and they can really check that in the hematological module. So you know what will happen. So if you track the hemoglobin and the MCV of cells and the hepcidin level, etc., you can see whether there's a crook in the business or not. And this is what they looked at. They look at the hematocrit, the hemoglobin, the MCV, the MCHC, the MCH, the platelets, red cell distribution width, the reticulocyte count, parameters, immature reticulocyte fraction, white cells. So if you look at all these things, they will change according to whether you exercise or whether you had a doping done. So that's my story. The bottom line is this: as I said, if you want to take a few things, I think one, lots of athletes do become iron deficient. It's because of decreased absorption. It is because of increased need, and it's also because of increased loss. And I showed you why they lose. They need, especially athletes going for endurance training and hypoxia training, they need iron supplementation. It's not easy to diagnose iron deficiency in these patients. You need to make sure that you take the blood after they've rested at least for 24 hours. And if they have these eccentric, this strange way of exercises, you need to really make sure 2 to 3 days, and you need to make sure that they're very well hydrated. So you need to check that they it's not absolutely 100%. Just don't do a iron study on an athlete and interpret it as if you've done that on a normal patient. And this is a very good article. If you want to read something interesting, I think Iron Considerations for the Athlete, a narrative review, it's good to read. It's fairly recent. And if you want it, I can send it to you.
Fantastic. Thank you very much, Pete. I think that's opened, excuse me. It's opened up a can of worms in many ways. Hearing you talk about autologous donations, and I'm just thinking of Lance Armstrong and Oprah Winfrey. It's amazing to think of how long they managed to keep that whole massive blood doping program under wraps for so many years. So I think they have to just constantly be keeping up with it's amazing with the human mind, the deviousness of the human mind and finding ways to beat the system. I'd like to ask if there are any questions, if you could pop them in the chat, or to put your hand up and ask questions. Do you have any look at particular interest in terms of female athletes and performance and heavy menstruation and effect on performance?
Yes, it's really, they as I said, if you look at the percentages, they're up to 35% of them are iron deficient, whereas with men it's about 11%. So they tend to be much more iron deficient, but it's also to do with eating. It's got to do with lifestyle, diet, not only loss. So it's the three factors. It's loss, need, and intake.
One of the questions I always have every time I go hiking on Table Mountain. So one of my interests, I do ultra marathons on trail and that sort of thing. And so I was looking at the hepcidin and the inflammatory markers, and knowing how awful I feel a few hours post marathon, I can imagine what my inflammatory markers are like. But it would be fascinating to take blood from tourists heading up Tatterklip Gorge here in Cape Town on a hot summer's day. We'd know, how much the plasma levels contract. I would never mind the amount of water they consume or do not take, what it would do to the electrolyte levels. I don't know how you would get ethics for that study, but it'd be very, very interesting to see.
And it's, as I said, it's not only endurance athletes. It's seen in a lot of exercises, and the advantage really of exercise lies in the long-term effect. It's the resetting of the system. That's what it boils down to. You reset your platelets, you reset your white cells, you reset your acute phase, and that's what the big advantage of. And you decrease your fibrinolysis, and that's what it boils down to.
Yeah. Do you have any idea is there any sort of time limit as to when we start getting these massive changes? So obviously someone after a marathon, you can imagine that's a major strain on the system. But you mentioned that paper earlier about just walking and the effects on iron absorption.
It's normally within a day that you see these changes. You see the acute phase, and then it sort of resets, and then you get the advantages. So it's quite early that you see the advantages of exercise.
Okay, all right. So as low as 5 kilometers, 10 kilometers, getting just lapping everybody on the couch.
Yes.
Has anyone else got?
Yeah,
yes,
thanks.
Chris.
If I may, Pete, that was excellent. Thank you. And also for highlighting the effects on the gut. So still for alcohol blood, often positive, but we see a lot of reflux in runners, and not so much bleeding, but often asymptomatic patients who don't suffer from heartburn either prior or even during the exercise training or the marathon. But what they do is they get a kind of a vagal response, which causes a gut to constrict, and they get a lot of air trapping. And when it's released, they get this purge of diarrhea, and it causes a lot of morbidity in runners, and it is quite common. And the way to treat it is to give an acid inhibitor, but also to give an anticholinergic, low-dose amitriptyline, for example. And I've got a lot of runners who are really bothered by this and often have to stop training or stop exercising at the time because of this acute pain. So reflux is very
runners GIT. It's very, very well known phenomenon. Can be quite debilitating.
Yeah, in fact, and it's silent. These runners don't really suffer from heartburn, and you just need a high index of suspicion.
Obviously the effects of exercise, being able to exercise, it's significant if you're anemic. And I know of at least one case, a colleague of mine who I used to run with and who was far, far fitter than me. And one day we realized he was lagging far behind. We tested his hemoglobin, but he's only 32. His hemoglobin was 9, and he had colon CA. Picked up early enough that he's cured. Picked up timeously. And if we went for the run and the fatigue, we may not have picked it up until it was too late. So it's well worth just having a high index of suspicion. And I think you've highlighted that very well. You need to fully work up patients, but in the correct timeous manner. There is a question, Sianda. Can you unmute?
Hi,
yes.
Great talk, Prof. I've been having signal issues. This might have been covered, but does this hold true for for athletes who do predominant resistance training or weight training, because I'd assume, you know, if you give greater muscle mass, then your hemoglobin should also be higher up.
They tend to get more of this muscle injury. So that's the type of training that you really get an iron deficiency and muscle injury. So
Is that with like the eccentric training?
yeah.
Okay. Does that
Okay,
answer your
thank you,
questions?
Prof. Yes, it does. Yeah.
Okay. Any other comments? Any other questions? I think we are heading up to 5:30, and I think we've had an excellent session. Pete, thank you so much for the talk. It was, I was looking at, I've already noted down a few of your references, and I've downloaded the papers
You're
already.
welcome. You're welcome. I'll send it to you.
Thank you so much.
Right.
And so thank you to the ECHO teams in India and University of New Mexico. There's a feedback form that's available in the chat. Please fill it in as how we can improve. If there are any topics that you would like in future, please let us know. The recordings will be made available on the Gastro Foundation website. Chris, thank you again for your support, as always, for patient blood management. And thanks to the sponsors of the Gastro Foundation. Next week, I believe the topic is endoscopy. And yeah, we look forward to having chairs of Sandy Thompson and two other speakers, Dr. Layla as well. So we'd love to see you there. And thank you again for your time, and have a great evening. Thank you.
Thanks so much, Matthew. And thanks, Pete. Again, excellent.
Pleasure.
Cheers, everybody.
Cheers.